I'm just going to talk a little bit about ENT in general and what ENTs do. Talk a little bit about myself, being new to the community here, and then I'll go through some ENT-specific problems and just give you a little feel for the field. So, first of all, my office, in case anybody is interested, is down at the Bridgeview Family Medicine office. It's the Malcolm Professional Building. Dr. O'Connor's office is what most people know it best as, just a couple blocks from the hospital. We opened in December of 2012, so I've been open a little over a month now, and accepting all patients at this point, accepting all insurances. We aren't, there's always insurance issues when you first start up, and so when you call, if you call, we might have to ask you a few questions and give you some disclaimers about things, but we're hoping to soon be rolling with everything. In terms of patients, we see all ages of patients from newborns all the way up, and in terms of the general issues that those people have, for the younger people, children, it's normally chronic tonsil infections or sleep apnea where we take the tonsils out, or chronic ear infections where we might have to put tubes in the ears. And then for adults, there's various things like chronic nasal congestion, chronic sinus infections, hearing loss, chronic throat symptoms like hoarseness or difficulty swallowing, or pain or a cough. And the surgeries for those can include nasal surgeries, septoplasty to help you breathe better, sinus surgery to help with the infections, and ear surgeries. And you'll notice that a lot of what we see in both the adults and in the kids are chronic issues. Chronic ear infections, chronic tonsil infections, chronic sinus infections, chronic nasal obstruction, chronic throat symptoms. The things that we do go one step beyond the medical aspect of treating. I do treat a lot of people medically, but a lot of your primary care doctors can treat the acute infections as they arise. It's when we want to do something else to prevent all these recurrent acute infections that we start talking about surgeries and things. Other issues that we might see someone for are things like if someone has a neck mass or a thyroid nodule, skin cancer or skin lesion, salivary gland problem, or a sleep apnea. And we do surgeries for all of those different things as well. All of the surgeries, most of the surgeries are done at the hospital. I do a few minor things in my office, but most are done at the hospital. And most surgeries are outpatient procedures, so you go home the same day. I'll talk a little bit about myself. You may have seen the article in the newspaper when I first came on, and this is just going to go a little bit beyond that. I graduated college from the University of St. Thomas, that's in St. Paul, Minnesota. That was in 1994, and I graduated with a degree in finance and math. I was on the football and track teams as well at that point. Then I went to college at the Kirksville College of Osteopathic Medicine in Kirksville, Missouri. And if anyone is aware of where Kirksville, Missouri is, then you're probably in the minority. It's a small town in the corner. And I have a map on here if anyone wants to come up and see it. While in medical school, I did go on a medical missionary trip to Nepal. It was in the Kathmandu Valley. We hiked around, I have some neat pictures here. And then I did my residency at Genesis Regional Medical Center in Flint, Michigan, or Grand Blanc, Michigan, which is a suburb of Flint. That was in 2007 that I finished. My first job after that was in Hawaii, on the Big Island of Hawaii. I was in solo practice there. That was a lot of fun. And then my wife and I started to have some kids and wanted to get a little bit closer to home, so we ended up moving. We came back to the mainland, and we're in Massachusetts for the past few years, Milford, Massachusetts. I have another map to show you because I doubt you know where Milford is, but it's near Boston. And then my family, I have a wife, she's from Bay City, Michigan, and I have 2 kids. Kinsale is 4 years old, and that's our daughter, and Colton is 2 years old. Things that we, as a family, like to do, we like to do a lot of traveling. We've been to a lot of different countries in Europe and around the States here. With the 2-year-old, as I'm sure a lot of you know, it's difficult to travel, especially fly, with kids that young. So as soon as he gets a little bit more cooperative, we're going to start traveling a little bit more again. But we also like to do other outdoor activities, hiking and biking, and camping, things like that. So let's go on to some common ENT issues. And at any point, anyone has any questions, I know this is not nearly as interesting for you as it is for me because I'm looking at all these neat pictures here. So please feel free to ask any questions. The first one is just nosebleeds. That a lot of people have nosebleeds, especially in the winter time. It's more common in the winter time because of the dryness of the air. The furnace is on, it dries out the air, dries out the nose, just makes it more conducive to bleeding. Most of the nosebleeds occur in the very front part of the nose where we can see it, where we can cauterize it if we need to. But besides the dryness, other things like a deviated septum will contribute to a nosebleed. And if you're on blood thinners, once it starts bleeding, it's going to keep going. So whereas a lot of people might blow their nose in the wintertime, get a little bit of blood streak mucus there, if someone's on blood thinners, that little blood streak mucus turns into a big mess. So I do have a neat, funny little cartoon that I'll try to describe for you to kind of break up the monotony here. If you can imagine two elephants in a house, the husband and wife, and the husband just walks in and the wife asks how the game was, and the husband said, the seats were terrible. I was in the nosebleed section, and you can imagine how that So, for treatment of nosebleeds, the first thing I like to do for pretty much everybody is, and we're not talking about while it's actively bleeding, we're talking about trying to prevent the recurrent nosebleeds from occurring, is just to keep the nose really moist. That can be done with humidifiers in your house, saline nose sprays, saline gel solutions or Vaseline in the nose. If you're on oxygen, of course, you don't want to use Vaseline in the nose because that can cause a fire, so don't do that. If you're on blood thinners, then make sure it's at the right level, make sure you talk to your primary care doctor, make sure that's monitored well. And then, of course, avoid nasal trauma in kids. One of the main causes of nosebleeds is picking the nose. And so if there is recurrent nosebleeds, we can cauterize the area. If it's an acute nosebleed, sometimes we can still cauterize it, but sometimes you need to go to the ER, get a packing put in if it just can't be stopped on its own. Sometimes we need to do a septoplasty to help with the nosebleeds, and sometimes we need to do even more involved surgeries to control the nosebleeds.
Can I ask you how long a cauterization typically lasts? About 2 years?
How long it's effective? It just varies for everybody. It could be permanent, it could be forever, it could be 1 day, which means it didn't really work to begin with. So most people, when we cauterize them, they're coming in because they're having a nosebleed maybe every couple of days, and then we cauterize their nose, and they come back 3 weeks later and they say, I haven't had any more nosebleeds. And maybe for the rest of that winter or whatever, they don't have any more nosebleeds. That's usually what happens. Going on to wax. Wax is a problem that we see a lot of people for. It's not really a problem, but it can become a problem if it causes hearing loss or contributes to ear infections. Wax is actually normal. It's good to have wax. Wax is made by modified mucus glands in the ear. The wax actually helps prevent infections from occurring. It keeps the ear clean. So it's good to have wax. but it can cause problems if it gets too much. The quality of wax over time can change, so as someone gets older, it might get more dried out, making it less likely to come out on its own, and so then it can contribute to hearing loss, and we might need to clean it out. Cotton swabs, lots of people ask about cotton swabs. Realizing that many people, if not most people, use cotton swabs to clean out their ears, the best advice is just to be careful, don't put it in too far. I have seen people puncture their eardrums with those cotton swabs. I've seen people really scratch the ear canal with the cotton swabs and cause an infection. I've seen the cotton tip come off inside the ear and it gets stuck there, and that causes infections and everything if that stays in there. It can, pack the wax in and cause, more problems. So most people use it without any problems, any difficulties, but just be aware of the potential issues with that. So in the office, many primary care doctors' offices use a syringe of water or some other wet way of cleaning it out. In my office, I like to either scoop it out with a little curette or suction it out with a suction. Candling, has anyone heard of candling or done candling? I always tell people, if someone asks, that it doesn't work. That studies have been done on that to see if it works, and it doesn't change the amount of wax in the ear canal. And it might feel like it's doing stuff, or it might seem like it is, but it doesn't. So that's just my take on that. Yes?
I've read some articles where research shows that for the cone and the fire to create enough lift in the hot air to actually lift an average sized piece of wax out of the ear, the candle itself would have to be 3 stories high.
I haven't seen that, but that's a nice addition to the lecture. So. So, okay, going on, reflux. Reflux is a common problem. Many people have reflux. Many people have reflux and don't know they have it. Most people think of reflux as causing indigestion, heartburn, upset stomach, those types of things, which is the most common symptoms that it does cause. I see a lot of people in my office because of throat symptoms. Reflux can come up to the throat and even up to the nose, but it comes up to the throat and causes hoarseness, difficulty swallowing, chronic throat pain, feeling of a lump in the throat, chronic cough, all sorts of symptoms. So whenever I see someone in my office with any symptoms of the throat, that's one of the first things that I start thinking of and start asking questions of. Most people, or many people, when I start asking those questions, they say, no, I don't have reflux. And then after I examine everything, I suggest going on a trial of reflux medicine, and they're very skeptical, of course, because they don't think they have any reflux. But after a few weeks or a month or two, they say, oh, all my symptoms are gone. And so it can be difficult to identify that sometimes. We do like to see someone in the office, though, who has these throat symptoms. So if you have any of these chronic throat symptoms, don't just start taking reflux medicine and presume that's it. There can be other things, cancers and things like that. So we definitely want to do an examination, take a look in the throat, make sure nothing else is going on, and if necessary, CT scans or whatnot. But when all that stuff is normal, then we start looking at these different treatment options. Besides reflux medicine, we always talk about lifestyle modifications for reflux. Don't eat late at night. When reflux affects the throat, it's usually because it's occurring at nighttime when you're asleep and you're lying down. When you're lying down, there's no gravity to keep the reflux, the acid, down, and so it can come up to the throat pretty easily. So don't eat late at night. I tell people to leave at least 4 hours in between eating supper and lying down for bed to give everything a chance to clear out of the stomach. Try to avoid fatty foods and spicy foods. Other foods, tomato-based sauces, caffeine, alcohol, all those types of things. And certain foods, mint foods for some people, and some people respond to just certain foods. And if you know that there's something that you'll respond to, try to avoid eating that at nighttime. Other things that you can do are raise the head of your bed up, put the head of your bed on some blocks. Don't just put an extra pillow under your head. You have to raise the whole head of the bed up so your whole body, shoulders and head and everything is elevated. All right, next one going on is skin cancer. Skin cancer, we see a lot of skin cancer, any lesions that might be present on the face. And I'm a head and neck surgeon, so I deal with these skin lesions, and skin cancer is pretty much on the scalp down to the clavicles, the bottom of the neck. But skin cancers can be anywhere, of course. In the head and neck, I can take care of them pretty easily. Doing both a biopsy for them if there's a skin lesion that's been there for months, gradually getting bigger, or years, gradually getting bigger, and there's a suspicious appearance to it. We might do a biopsy. If that shows that it's cancer, then go on with removal and repair of that. The treatment for skin cancer is almost always surgery. There are a few exceptions where we might talk about radiation, but almost always surgery.
Do you know, or do you practice the Mohs procedure?
Mohs procedure is, that's a good question. Mohs procedure is usually done by dermatologists who are board certified in both the dermatology aspect of things as well as the pathology aspect. So they cut out the skin lesion and then they themselves look at it under the microscope and determine if all the cancer is gone, with the idea being that two parts of that. One is that the surgeon is the one doing the cutting out and the viewing of it under the microscope to see if it's cancer or not. So that surgeon, that one person, is better able to know where the cancer came from, what part might still be present, and answer those types of questions. Ideally, the other part of that is that they're able to take out the most minimum amount of tissue necessary to remove all the cancer. So when I see someone, I would take someone to the hospital to do this removal of the skin cancer. I would make some markings around what I think is the cancer, and then remove that, plus a little rim of what looks like normal tissue to me. So then I would send that to the pathologist while the person is still in the operating room. The pathologist would, at that same time, look at it and determine if there's any cancer left. If there is, they would say, okay, you have to remove some more cancer in this area. We mark it like a clock, 12 o'clock, 1 o'clock, 2 o'clock, 3 o'clock. They say from the 12 o'clock to the 2 o'clock margin, there's more cancer. So then I'd go back and remove a little bit more in that area. With doing it that way, it's certainly possible that I remove more tissue than what needs to be removed. And so the dermatologist, who is a Mohs surgeon, almost always it's a dermatologist, but ideally they can take out a smaller amount of the area, a smaller area, and then meaning they would have less of a defect in the skin to close. So it sounds really great. In reality, the difference between the two, the long-term outcomes, the cosmetic outcomes, there's really not much difference. In terms of the effectiveness of the surgery, in terms of how things look afterwards, there's not that much difference in reality.
Does the depth of the cancer vary?
Yes, it does. And that's another thing that they look at to make sure we all cancers that go deeper are a little bit more concerning. Yeah. Skin cancers very rarely metastasize to lymph nodes. Other types of cancers do metastasize to lymph nodes and the neck and everywhere. Skin cancers rarely do that, although they can. So Risk factors for skin cancer, of course, sun exposure, tanning, those types of things. So another thing that we do a lot of is taking care of people with difficulty breathing through the nose, nasal congestion. Causes of that might be a crow's in a crooked manner. Enlarged turbinates. Turbinates are air fins that are inside the nose, and they help guide the air flowing through the nose so that it's a smooth flow of air. The turbinates also warm the air and humidify the air that we breathe in. If those are enlarged, those can block off the airway. Allergies can congest things inside the nose. And other irritating factors, they don't necessarily have to be allergies, but if someone has is irritated by perfume, that can make the nose get congested. It's not necessarily an allergy, but it just causes things to congest. So the treatment is to treat anything that might irritate the nose, allergies or these other irritating factors, try to avoid those things. Other things that we try are saline irrigation inside the nose or a saline nose spray. Nasal steroid sprays are common. Those really help to open the nose up, like Flonase, if anyone's heard of that. And then if all of that stuff fails, we go into surgery. And that usually helps people breathe much better through the nose.
I don't know if this sounds silly or not, but can you tell, does the person have to be affected by it when they see you, or can you tell that from the way things are laid out by looking at it?
If someone is, so you're talking more about like an intermittent congestion? Like
Yeah, or
sometimes
maybe you get it at a certain time of year.
Right.
Do you need to come in when you have it?
No, not necessarily. Just by you telling us that history, if you know what causes it, we say, well, it might be due to allergies. Let's treat you with allergy medicine or the nose spray. It might be due to this, a change in weather or whatever. Let's have you do this during that season. And if that takes care of it, great. If it's not a persistent problem all year long, it's less likely to be an actual anatomical problem. So if sometimes of the year you're breathing just fine and other times of the year you're not, it's probably that the septum is relatively straight, and it's probably that the turbinates are relatively normal. And it's just those exposures that make things a little bit worse. There are some surgical things that we can do even in those times if medical treatment doesn't help during those times. So. Going on to tinnitus, or ringing in the ears. This is a problem that a lot of people have, a lot of people with hearing loss have it. Tinnitus is just any kind of noise in the ear. It can be ringing or a tone in the ear, or different people describe it different ways. Causes, the main cause is usually hearing loss and nerve hearing loss, but a lot of things can contribute to it. Lots of medications have tinnitus as one of the side effects. And so, in fact, if you look on, if any of you are on medications, if you have the little leaflet at home that comes in the box and you read all the adverse symptoms, you might find tinnitus in there. It doesn't always cause this in everybody who takes it, but it can. And so if you have tinnitus and you're on a lot of different medicines, might as well look through those and see, if that could be a factor. If it is, you might be able to talk with your primary care doctor to switch it to something that is less likely to cause the tinnitus. Other factors that can cause it: stress or anxiety, sleep deprivation, caffeine, nasal decongestants, aspirin can cause it. And that's not saying that if you get rid of all of this in your life that the tinnitus will go away, but you might notice if you don't get very much sleep one day, or you have a lot of stress, or you drink a lot of caffeine, that the tinnitus might be worse. So you can kind of try to manage it those ways. If you come in to see me, I'll of course look in the ears, and if they're all normal, we'll say, let's get a hearing test. That's just kind of the standard evaluation to get a hearing test. Hearing tests can identify if there is hearing loss, but it can also give us some clues as to just how the ears are functioning in general. Treatment, there's really no good treatment for it. There's not something that we can give you to take it all away and get things back to normal. There's a lot of research going into it. They're working on medications, stem cell therapy, different things, listening to different tones for a certain period of time can make the tinnitus go away for a certain period of time after you listen to these things. But in general, most people say that when they try all that stuff, it doesn't do what they want it to. So we started telling people about coping strategies, and if the tinnitus bothers you mostly at nighttime when you're trying to sleep and it's quiet out, then having a fan on or the radio on or something like that. Hearing aids, if you have hearing loss, hearing aids can help. They can amplify the outside noise so you don't hear the tinnitus as much. Of course, that's not going to work when you're trying to sleep and you take the hearing aids out. Chronic sinus infections are another thing that we see a lot of, and that's either recurrent sinus infections, meaning several a year, 3 or 4 sinus infections a year for several years in a row, or symptoms, sinus symptoms that last for more than 3 months at a time. And symptoms can include things like nasal congestion or nasal drainage or pain in the face, fevers, those types of things. For chronic sinus infections, there are a lot of contributing factors, just like nasal congestion, allergies, deviated nasal septum, viral infections, asthma can contribute to it. Some people just have bad sinuses. That's probably the best way to say it, is that regardless of what you do for it, it's just, there's not much improvement. So treatment is, saline irrigation is a good standard therapy that a lot of people find a lot of benefit from. After that, nasal steroids like a Flonase nose spray, long-term antibiotics, meaning 3 or 4 weeks of an antibiotic, and then any other contributing factors, whether it's asthma or allergies or other irritating factors to the nose. And if all that stuff doesn't work, then we can talk about doing surgery and opening things up. Chronic tonsil infections. I really apologize for for you not being able to see all these pictures. It would just make things a lot more interesting than listening to me. But if I knew how to do cartwheels and backflips, I'd try to do that for you. But I'll just keep going as I am. So tonsils, chronic tonsil infections. That can either be recurrent tonsil infections, 3 or 4 a year for several years in a row, or chronic symptoms lasting a long time. If the tonsils get really big and they cause difficulties with swallowing food, or if they cause other problems, those are all things that we see people for. Tonsillectomy is still one of the most common surgeries that we do. And it really helps a lot of people taking the tonsils out when they have these symptoms. The deciding factor as to whether to take the tonsils out or not, I kind of leave up to the person. It's really a quality of life thing. If they're having 3 or 4 infections a year and they're fine treating it with antibiotics or whatever, then they can keep doing that if that's fine for them. Some people, if you don't want to keep treating it like that, then we can take the tonsils out. So it really is kind of a quality of life thing.
Question.
Yes.
It used to be that when you got your tonsils out, they also removed your adenoids, and I've never quite understood why or what they were removing.
Yep. Adenoids, so tonsils are lymph tissue in the back of the throat. Lymph tissue helps us to fight infections. The adenoids are also lymph tissue, but it's in the very back of the nose. You can't really see the adenoids. And so the adenoids are present in children. Around age 12 or 13, they gradually regress and go away. So adults shouldn't have adenoids anymore. So if someone's coming in with chronic tonsil infections and they're a teenager or in their 20s or 30s or 50s or whatever, we usually don't do anything with the adenoids because they're usually gone. Sometimes they do stay, and if they stay and they cause problems, then we do take them out for adults. For kids, we do take them out because they can cause problems in kids, recurrent infections, nasal infections. They can obstruct things, cause sleep apnea if they're in there, and they're pretty easy to take out at the same time. So. Sleep apnea is a common one. It is a medical condition. It's not just an annoyance that your spouse or significant other wants you to get treated for. It's a medical condition, and it can increase your risk for things like heart disease or stroke, pulmonary disease, lung disease, things like car accidents if you are driving and you fall asleep, and just daily interactions with people if you're always falling asleep or you can't stay awake when you're reading something at work. It can just be affect a lot of different things. So because it is a medical condition that can cause those medical problems, it really should be treated one way or another. The most common treatment is the CPAP machine. So to diagnose sleep apnea, if you aren't aware, snoring is kind of one of the first signs of it, the first thing that might clue someone in. But if they have pauses, if someone has pauses in their breathing, they wake up gasping for air, they feel very sleepy during the day, they fall asleep easily during the day, they wake up not very well rested. Those are all symptoms of sleep apnea. And so you should talk to your primary care doctor or come in and see me, have a sleep study ordered. The sleep, where you have that done, depending on how their protocol is, they can do the sleep study and then they can fit you with a CPAP machine if you do have sleep apnea. And that's kind of the first line treatment for it. And there's a lot of different masks and different ways that they can adjust things to make it more comfortable. Lots of people say, I don't even want to try it. It's very good to try it because besides the CPAP, there's not a lot of other good options. We can do, there are oral appliances to help with sleep apnea and snoring. They're not as effective as the CPAP machine. You can use sleep positioning, meaning if you only have sleep apnea when you're on your back, you can try to sleep on your side. That doesn't help most people. And if all else fails, we can do surgery. Surgery can be trimming off stuff in the back of the throat, take out the tonsils, open the throat up a little bit more. That sounds great. It sounds like a good alternative to avoid the CPAP machine, but it's really not that effective. It's not effective enough to say that should be a first line of treatment. So I always have people really give the CPAP machine a good try, because even if you go on to surgery, this CPAP or this uvulopalatal-pharyngoplasty that we do, you still might need the CPAP machine after that. You still might have sleep apnea even if you have this surgery done. So it's a good idea to stick with the CPAP if you can. And if the uvulopalatal-pharyngoplasty doesn't work, there are further things that can be done that just get more and more involved, with the most definitive type of surgery being a tracheostomy. So from time to time we do have to do that for people. So going on, I think this might be the last, so yeah.
Could I go back to tonsils and adenoids
Yeah.
for a second? Do adenoids ever affect eustachian tube function?
Yes, they can. The eustachian tube, for people who aren't aware, connects the ears with the back of the nose. No, it's all connected in the back. The ears are connected to the nose by the eustachian tube. And the eustachian tubes come into the back of the nose right where the adenoids are. And so, especially in children, if there's recurrent ear infections, one of the things we consider is whether the adenoids are plugging up the eustachian tubes, whether the adenoids are so big that they're plugging up the eustachian tubes. If that's the case, then we might remove the adenoids for that reason. Is that what you're wondering about? So cancer, were you right? I saw a hand kind of coming up. No. Cancer of the head and neck, pretty common. Does anyone know what the biggest risk factor is? Smoking. Biggest risk factor. If you smoke please stop. We don't need to tell you, you know that it's bad for you, but you just need to say it again. If you know people who do smoke, ask them to stop. If you or they have tried to stop in the past and it didn't work, give it another try. I almost never, well, on occasion I'll hear someone who says, I just quit cold turkey, no problem, it was easy. Usually someone tries to stop several times before they actually do stop. So keep trying. But it's the biggest risk factor for cancer in the head and neck area. Symptoms in the head and neck area of cancer, and we're talking about cancer, not skin cancer, but cancer in the throat, in the mouth, and the lips, and the cheeks, and the tongue, in the tonsils, in the larynx, vocal cords, that type of cancer. The most common symptoms are either chronic sore throat, chronic lump that you can see or feel, a chronic neck mass, a neck mass that you've had for weeks or months, just maybe gradually getting bigger. Those are all concerning findings for cancer. And you said, you note that I said a chronic sore throat, just like people who might have reflux have a chronic sore throat. That's one reason we want you to come in, get checked, make sure it's not something like a cancer. So if there's a neck mass, it's because the cancer has metastasized to a lymph node that's in the neck. Lymph nodes, as we talked about, lymph tissue helps to fight infection. There's a lot of lymph nodes in the neck, and when cancers metastasize, they go to the lymph nodes in the neck. And there's hundreds of lymph nodes in the neck. And so that is something that we need to find out about. If you come in and you have a neck mass, then I would want to put a needle in that, usually, to take a fine needle biopsy of that. I send that to the pathologist and they tell us what it is. So for the workup of this, let's say there's someone with a neck mass, we do the needle biopsy and it comes back as cancer. There's a whole set of things that we have people do. We need to have them see the medical oncologist, the radiation oncologist, a dentist or oral surgeon, get a CT scan, get an MRI, get labs done, see a speech therapist. All these things are done for pretty much every patient that has cancer in the head and neck. It's kind of a big ordeal, but the medical oncologists, the radiation oncologists are usually the ones that organize all that stuff, and they have it down pretty good, and can get people through that sequence of things pretty well. Treatment for cancer in the head and neck can be radiation, chemotherapy, or surgery, or a combination of all of those. It just depends on the type of cancer, where it is, how advanced it is, that we make those decisions. So that pretty much brings us to the end. Does anyone have any questions about it?
Great. So we got
I had two. Did somebody do that? I just was wondering if your practice focuses on surgery, and also are you going to be here full time, or are you going to be going between St. Ignace, etc.?
I'm here full time. I don't have any satellite offices anywhere else, so I'm here. Focusing on surgery?
Yeah, is it more focused on surgery, or is it general?
I would consider myself, and most ENTs would consider themselves surgeons first, and then the medical aspect second. I do have a lot of patients that I see on a routine basis for just medical issues. Most of the things that we see people for can be treated, like routine ear infections, sinus infections, sore throat, whatever. All that stuff can usually be treated by primary care doctors pretty easily. It's when it gets to be more of a chronic issue, or when the primary care doctor doesn't really know what's going on, or they've tried to treat it and it's not working, that they then send them to us. And so our treatment could include surgery, or it could just be an alteration of some of the medical stuff. Any other questions?
I have a question. What causes phlegm, especially in the morning after you slept all night, that you get in your throat?
That's a question that I get a lot. And the best answer that I can give is that it's due to dryness in the airway that's going on throughout the night. We all have mucus glands in the nose and the throat and the sinuses. And in the nose and in the sinuses, they make about 1 liter of mucus a day that then drains down the back. Most people don't notice it because it just drains down like it's supposed to. Usually when it gets too thick and sticky is when people start to notice it, and they come into my office and say, I have postnasal drainage. I really discourage people from taking an antihistamine to try to dry that up, because that's just making it more dry. So I really encourage use of a saline rinse, saline irrigation, saline spray, or whatever. At nighttime, if it's happening at nighttime, use a saline spray at night before you go to bed. Look into whether you need a humidifier by your bed at nighttime to make it more moist, the air more moist. If someone sleeps with their mouth open, that can really dry the throat out in particular. And then when you wake up, if all else fails, when you wake up in the morning, you really rinse out the nose with a sinus rinse or a nasal rinse. If you don't like any of those answers, we can always talk about doing a CT scan to see if there's any sinus disease or anything that might be going on, but that's not very common to have that be the case.
I had 2 questions. One, I saw one of your slides over here, one of the only 2 that we ever did see. But it said facial plastic surgery, I believe. Was that referring to skin cancer, or does your scope of practice extend beyond
cosmetic surgery? Yeah. So facial plastic surgery is kind of divided into cosmetic surgery and reconstructive surgery, like you mentioned. The reconstructive surgery part is for things like skin cancer. Once we remove it, we do the reconstruction of it with skin flaps or skin grafts or things like that. The other part is, and I do that. I do that all the time. The other part is cosmetic surgery. I do cosmetic surgery. Right now in my practice, I'm focusing mostly on general ENT and the skin cancers and other surgeries, just to get that part of things, address those issues in the community first. At some point I might begin to incorporate more the cosmetic surgery aspect of things, but I'm just not focusing on that very much. I don't mind if anyone has any cosmetic surgery or cosmetic questions or whatever, they want to come in for a consultation, a free consultation. That's not a problem. I'm seeing people for that. I'm just not focusing on surgery or anything like that right now.
Okay. And then the second thing, I was wondering if you had any experience with bone-anchored hearing aids?
Yep, I have placed those in the past, and many people do like those a lot. Are you familiar with them?
Yes.
So for those who aren't familiar with them, if someone has hearing loss, and certain types of hearing losses can be fixed very well with a hearing aid that we implant in the bone behind the ear. So we screw in this little metal post into the bone behind the ear and then hook an attachment onto that that transmits the sound directly through the bone to the nerve. That's a very effective way of improving the hearing in certain cases, and many people really like that a lot. It does, of course, require that you have this metal post sticking out of the side of your head for most of your life. Now, when you don't have the hearing aid on, the hair normally covers it so you can't see it. It's not like Frankenstein walking around. But it is very effective.
There may be a new magnetic version out. I've just heard
there are
glimpses and seen glimpses and heard rumors that doesn't require the buttress.
Right. There are some of those new ones. I don't know if they are mainstream yet or if they're still just being done at the, I guess, the research places. And there's a whole range of other things as well, other implantable hearing aids that we can do even a more major surgery to implant. And then there's nothing on the outside that you have to wear. And you just have to have surgery to change the battery, like, I don't know, every 7 years or something like that. And so, insurance companies don't pay for some of these things. I think that was like $25,000 if someone wants to splurge for it. So there are a lot of insurance issues when we're talking about these types of things as well.
How about cleft patients? Have you been treating any of those? Or?
In my training, I did
Okay.
cleft palate surgery, cleft lip surgery, but I have not done any since I've been out of training. And I think for their best outcome, I think it would be best if they would go someplace that does it all the time. Do you have any places where they do those?
Well, Ann Arbor, of course.
Ann Arbor, yeah. Any other questions?
So are you pretty happy to take out tonsils if we in the orthodontist say, this kid needs her tonsils out, are you pretty happy to do that if the parent consents?
Oh yeah, well if they, I'd always ask them if they meet the criteria. Criteria meaning the actual criteria I go by are 3 tonsil infections a year for several years in a row, 5 tonsil infections a year for 2 years in a row, 6 or 7 tonsil infections in 1 year, or if they're having sleep apnea symptoms like a child, and it's pretty obvious it's due to the tonsils, or if they're having other symptoms that I think, yeah. And so I'd kind of go through that whole discussion with the parents. I don't have any problem taking tonsils out. I enjoy doing surgery, and I'll take them out if any of you want to have them taken out. Sign me up. But yeah, I mean, we'll certainly see them. And if they come in and I talk with them, and it's happened from time to time, and I know you've seen this happen as well, when they might give you a different story than what they give me, and so sometimes there's that happens, but yeah.
I was always told that tonsils protect your heart, do they?
They protect your heart?
Yeah.
I haven't heard that. I'm trying to think of how that would work. I don't know. Yeah. We think tonsils, and tonsils, I said at one point, I said that tonsils are made of lymph tissue, which helps to fight infections. And yet, people with chronic tonsil infections, they get a lot of infections.
Mm-hmm.
So does taking the tonsils out cause more tonsil infections? No. Most people who we take it out for that reason, for chronic tonsillitis, have much fewer infections. They might go down to 1 infection a year, and it might just be a little minor infection that they have. We think that the tonsils and the adenoids are most effective in the first maybe year or so of life, when most kids are putting everything in their mouth. It's kind of the first line of defense for all the viruses or bacteria that might go in the body. But after that first year, it really doesn't change. When we take them out, it really doesn't change the number of infections that they get. Any other questions?
Is Bridgeview Plaza on Magazine and Spruce, or is it somewhere else?
It's on Magazine Street, just right off of Spruce.
Okay.
Yeah. And I do have a picture of that.
Great.
So,
So this isn't really a question, but I just, I know firsthand what the demand is in this area for an otolaryngologist. And the community at large might not realize it yet, but we're really glad to have you here. We really need your services. Need it for a long time, and we're really glad to have you here.
I appreciate that. And on that note, in case you do call for an appointment, we all, right at this point, we are requesting that all the patients are referred by their doctor, just because there has been a backlog of people waiting to see an ENT. We want to make sure we see the patients who, really need to see us, that their primary care doctors are at the end of their line with treating them, and they need to get them into the next level. So for now, that might change at some point once kind of the backlog of people has been treated, but for now, that's, but I appreciate the sentiment.
All right. I think we're done. Appreciate y'all coming. If you have any questions, you can send them to me, and I can get them to Dr. Wallace. You can go to Dr. Wallace directly, of course. We appreciate you coming, and we'll be doing this every month, a different one, so keep looking for the options that are out there. And he is saying, eat food before you go.